This presentation is about eMERSE, an easy-to-use self-service research engine and chart review tool for EHR notes. My name is David Hanauer, and I am in the Department of Learning Health Sciences at the University of Michigan. So some brief background is that it's been estimated that approximately 80% of electronic health record or EHR data are in free text form. And that's important because while most people use the structured data because it's easy to get at and utilize, the majority of really valuable data are in free text, which are much harder to access and utilize. It's really important for the data to knowledge component of a learning health system. Free text is challenging to use, especially for non-technical researchers, and this is partly because traditional NLP systems are very complex. The eMERSE solution is what we have developed that we are now trying to provide for users here at Michigan as well as others across the country. It's a free text search and text processing platform. It's easy to use with high user satisfaction, tailored specifically for EHR data, enterprise grade, easy to support, configurable with roles privileges to control access. It assists with cohort identification, data abstraction, research, QA and QI projects, operations, and more. Currently, it's used at 7 academic medical centers with 8 more currently installing. It's been used in over 600 papers and abstracts, and it's free and open source. There are more things coming that we're working on currently. One is the eMERSE Research Informatics Network, which will allow real-time secure cross-site queries. And we're also working on embedding NLP for negation, uncertainty, subject, named entity recognition mapped to UMLS concepts. The little screenshot at the bottom of this slide just shows some of what we're working on, where you could search for terms such as serous carcinoma, and then we've identified other things in this text here, such as negation, where it says had no history of cough, sputum, or dyspnea. If you're interested in joining our community, we have eMERSE community meetings open to everyone everywhere. They're held about quarterly. And if you're interested in learning more, please contact us to schedule a time with your team to discuss implementation planning, discussion about research strategies using the system, live demonstrations, or training. Our email is emerse-team@umich.edu. And I just want to acknowledge our team, Lisa Ferguson, myself, David Hanauer, Kellen McLean, and Guan Wan. Thank you very much.
Greetings. My name is Pawan Goyal. I'm with the American College of Emergency Physicians. Very excited to be presenting to you our topic today, which is on standards, interoperability, metadata, technical models, and infrastructure for computable biomedical knowledge. ACEP started an Emergency Medicine Data Institute, and the mission of the institute is to revolutionize emergency care through data innovation, automation, and collaboration. The vision for Data Institute is to pioneer a healthier future through data-driven care. The important aspect of this Data Institute is to collect robust data from various clinical sources, including from electronic health record, across various uses, such as for disease purposes, understanding the treatment that was offered in emergency department, who came to emergency department, and did they get equitable care. But the big focus is how do we do quality improvement on longitudinal basis and establish standards of care at a global scale. Emergency Medicine Data Institute has 4 pillars. The first pillar is focused on the data registry component, which is essentially collecting data and normalizing, harmonizing data to be useful against various use cases. The second big focus is quality improvement. Once we have data, we go through 5 stages of data maturity model to convert that data, which is raw facts and figures, into information by putting a patient and the location context, taking that information to convert into knowledge, which is essentially understanding, why patient came to emergency department and what treatment was rendered, taking that knowledge and converting them into wisdom to understand what clinical workflow and clinical policies and best practices were deployed. In spite of those best practices, what were the variability and outcomes in the care? And the level 5 is to taking that knowledge into a sustainable change management, creating package of knowledge and disseminating that knowledge. We do that through our third pillar, which is through various grants and research and analytics where data is made available. And fourth is a measurement philosophy. What should we measure? Why should we measure? Main focus has been on conditions where minutes matter on the patient outcome, such as stroke, burn patients, trauma, heart patients, etc. Where is the data being used? So data became very valuable during COVID. During COVID, we tracked what was the change that was happening in the number of patients coming to emergency department. And we did see a very significant dip, almost 40% patient volume reduction during COVID overall. But then we tracked them around the acute conditions such as cardiac, venous thrombosis, and myocardial infarction, etc. We also tracked the changes in pediatric versus adult visit, and there was a significant drop in pediatric emergency visits as well. Happy to share more details and look forward to more interaction with this group. Thank you for the opportunity to present today.
Hi, my name is Joanne Dane-Bostel, and I'm here to tell you about the Scientific Evidence Code System. I'm an employee of Computable Publishing and a member of the board of the Scientific Knowledge Accelerator Foundation. The problem we're trying to solve is a lack of a common vocabulary to talk about science, which leads to poor scientific communication. This makes scientific evidence less usable and prevents advancement. Existing vocabularies are incomplete, some are inaccessible, and many are incompatible with one another. On the screen, you can see vocabularies from 5 different systems with 5 very different definitions for clinical trial. We set out to create a code system for the expression of science that is findable, accessible, interoperable, and reusable. We began by publishing a 13-step protocol, and highlights of this protocol include gathering a global expert working group of researchers, statisticians, clinicians, guideline developers, systematic reviewers, and patients. We identified 7 existing tools and systems and integrated terms from 27 different ontologies. Our voting process also leads to consensus. We also realized that we needed some software support for our project. The SEVCO code system is now fully represented by a FHIR code system resource on the Fever platform. Voting for term definitions takes place using My Ballot software on the Fever platform. And here you can see an example of a ballot with the opportunity to vote and leave comments for terms. So far, the Scientific Evidence Code System has 3 sections: study design, risk of bias, and statistics. As of August 2023, we've completed the study design code system, which consists of 76 terms, and a depiction of part of that study design code system is shown in the lower left panel of your screen. It was done with 42 experts from 18 different countries. The statistics section has 258 terms, 97 of which have been defined and approved so far, and so it's 38% complete. And the risk of bias section has 260 terms, 169 of which have been defined and approved, and so it's 65% complete. And we also have some real-world implementation already of the study design code system. If you go to clinicaltrials.gov, you can download the records in FHIR through an API, and the resulting research study resources in FHIR use a value set which incorporates the scientific evidence code system. And the FHIR resource structure definitions for research study and evidence resources in FHIR have bindings which include value sets from SEVCO. Final slide here. You can see that the SEVCO code system is part of the Health Evidence Knowledge Accelerator. We have 15 scheduled meetings per week, and we would love to have your participation. You can go to our project page at fever.net/HEVCA and join our group. Thank you.
Good day, everyone. I'm Dr. Miguel Aljibe, and on behalf of my team at the Standards and Interoperability Lab and our project leader, Dr. Alvin Marcela, I'll be giving a very short presentation for the 2023 Global MCBK meeting on the lessons from applying the WHO SMART guidelines in the Philippines. So, just a quick background, hepatitis B and C are an endemic problem in the Philippines, affecting some 10 million Filipinos. And the public health response to this requires that we know the number of people diagnosed with the disease, the number of people being given treatment, and the number of people who are cured of the disease. The problem, however, is that we don't know the number. The data is scattered among the different EMRs and hospital information systems of the different clinics in the country. It's because of this problem that we've decided to start the Viral Hepatitis Project in order to be able to aggregate and collect all these data. The Viral Hepatitis Project provides a terminology service and the application of the FHIR standards to the EMRs. And this is the WHO SMART guidelines as it is applied to the Viral Hepatitis Project. At L1, or the narrative level, we did an analysis of the relevant laws and policies with regards to hepatitis care and management in the Philippines. At L2, or the operational level, we had a consensus building with the Department of Health and the Hepatology Society of the Philippines with regards to the case report and the care form elements, and in mapping the data elements of these forms to the different semantic standards like LOINC and SNOMED. At L3, we created our FHIR profiles and implementation guides based on the work on L2. L4, we gathered the different EMR providers and taught them how to consume FHIR resources and submit to our FHIR server using their data. And L5, although experimental, we tried to create data analytics based on the data, the synthetic data that was submitted by the EMRs during the L4 event. So what are the important lessons during this project? Well, the theme here is governance. First and foremost, there's a need to provide orientation to policymakers on the WHO SMART guidelines. There's an importance in providing training to EMRs on FHIR consumption. We have to organize more frequent hackathons on different use cases so that the software developers and other stakeholders can practice. And most importantly, EMRs are willing to use FHIR and other syntactic and semantic standards if there is a directive from the authorities. Again, the importance of governance in the health information exchange. With that, thank you so much for taking time to listen to our short presentation, and have a good day.
Hello, everyone. I'm Shi Tongyue from National Institute of Health Data Science at Peking University. Next, I will report on our work. ICU mortality prediction based on patient groups identified using multivariate time series clustering. We all know that can help physicians in ICU to identify patients with high-risk mortality at an early stage, facilitate the provisions of personalized interventions, and that's mainly to improve the patient outcomes. We use 5 vital signs of patients within the first hours of ICU. There are temperature, heart rate, RR, MIP, and SpO2. We use the MIMIC4 dataset published by MIT. From the figure, we can see that our main work is divided into 4 major parts: dataset construction, patient cohort processing, example clustering model, and subgroup result analysis. By our example model, 3 distinct patient subgroups were successfully classified. We can see that they have different trends in 5 different vital signs trajectories. Then, as the screen sees, we have developed a patient subgroup clustering system to conclude an example model based on multivariate time series vital signs data in the first 8 hours of ICU was developed in this study. And 3 distinct subgroups were identified. The development of an ICU mortality risk prediction model is still ongoing. So what we next to do? We plan to implement the patient grouping and mortality prediction models in practice and evaluate real clinical effects. Okay, that's all. Thank you.